My name is Dr. Jason. I'm from the National Cancer Society Malaysia and CSM. We're an NGO non-profit, and today we are having this monthly SKD series for the Cancer of the Month. And this month is special because we're going to talk about breast cancer, and we have a very lovely and amazing speaker for you all today. Right? She's none other than Prof. Aishah Taib, a senior consultant breast surgeon and professor at the University of Malaya's Department of Surgery since 2012. She leads the Cancer Research Institute with an impressive 234 publications and H-index of 36. Her research emphasizes patient care and outcomes. She plays an active role in medical education, training for the Master of Surgery program, and examining exit vivas for breast and endocrine surgery. Prof. Aishah has supervised numerous theses from PhDs to clinical masters. She's also a member of various medical committees and organizations, including the National Committee for Breast and Endocrine Specialist Evaluation. Additionally, she leads efforts to improve cancer care access in the Greater Penang City, serving as a principal investigator for community studies focused on early cancer diagnosis and survivorship care. Prof. Aishah is a dedicated advocate currently presiding over the Malaysian NGO Together Against Cancer. So if you have any questions later, please leave it down in the comments throughout the session. Please just leave it down there. We will address it from time to time throughout the session, and there'll be one large Q&A session towards the end. So, Prof. Aishah will be presenting about empowering primary care providers in breast cancer care from guidelines to early detection. And without further ado, actually, Prof. Aishah is actually a huge mentor of mine, and she is amazing. Hearing her speak just brings you life, and it's just amazing to hear her speak about her work and amazing of her care for cancer patients. So, without further ado, Prof. Aishah, take it away, doctor.
Yeah, thank you, Jason. Jason, you make me very embarrassed with your very nice introduction. So, okay, I hope I won't disappoint anyone this morning because it's Saturday morning, going to the afternoon, and we have about 2 hours. So I think feel free to put in some questions, or, there are always questions, but even if it's not related to the topics that's been presented, please go ahead and, all right. So let me see if you can see the screen. Are you all okay with the screen? Okay, there you go. All right. So I think the title is very apt, I think, because we've always very well known in Malaysia to have fantastic guidelines, but somehow we haven't been able to implement it in a very cohesive manner, and we often work in silos. So today, let's talk about guidelines and how do we get on to early detection of breast cancer. So, I mean, as usual, lecturers in the university, we always go into the outline. So my first section would be, is breast cancer really significant? Is it something that we really need to worry about? Maybe we can go ahead and also look at risk factors for breast cancer, so that I think as general practitioners, you may want to be able to communicate that with your patients. And of course, let's go into the early detection of cancer and treatments, and we look into the Malaysian clinical practice guidelines, and look at what available resources out there for you to educate your patients, as well as maybe even improve your capacity in cancer care yourself. And lastly, maybe a little bit on our projects in UM. So this slide is very interesting because in 2020, this slide from blue, it has turned into pink. So essentially, breast cancer is the most common cancer in the world today. And knowing how significant it is, we have to try to see what we can do to improve the outcomes of the breast cancer patients, because I will show you in a little while that we are not doing too well in Malaysia. So this is the Global Cancer Observatory from the WHO website to show that the burden of disease will really be in Asia. So we as Asians, of course, Asia has actually the largest, if you look at different parts of the world, it's actually the most highly populated, and we know that essentially our population is aging, and hence cancer would be one of the most important things that we need to address. So breast cancer in Malaysia, this is the common cancers, and you can see even you put men and women together, breast cancer is the commonest cancer, making up about 19% of the cases. And secondly is colorectal cancer, another cancer that somehow has missed a lot of opportunities in Malaysia, because both of these cancers can be screened where it can be detected even without symptoms. And then we know our Malaysian cancer registry is quite, it's not really updated because the last data we have is right up to 2016. So a projection of the cancer cases by Global Can, also from the WHO, using our regional registries, show that yes, breast cancer is still the commonest, and second is colorectal. Okay, so when I put up this slide, and often people always talk about the top 10 causes of death in Malaysia, somehow we don't see cancer significantly being one of the top 5 causes of death. And really, I mean, unfortunately, in 2022, we can see that COVID-19 actually led in all the cause of death for that year. But if you go back to pre-pandemic and post-pandemic, we will probably see ischemic heart disease being the most common cause of death in Malaysia. And you can see that number 3 is pneumonia, number 4, cerebrovascular, and then even transport accidents is like top 5, okay? So what happened to all the cancer patients? So unfortunately, if you can look at number 7 and number 10, then you start to understand why when all of us just experiencing being a Malaysian know that, you know, if you've hear causes of death among your relatives or friends, it's usually a heart attack or cancer, isn't it? So you can see that if you aggregate all these cancers together, it can really be the number 2 cause of death, which is the overall cause of death. And more sadly, if we aggregate it together as a cause of premature death, that means death before the age of 70, cancer is number 2. So this is something that we need to really focus on. And unfortunately, our investment in non-communicable disease in Malaysia is very, very sadly a bit behind. Unfortunately, even with the Twin Towers, you know, with all our resources, we are not able to get good outcomes. So how do I know our outcomes are not that great? So we had a publication back in 2018 from the Malaysian Ministry of Health. And you can see that for Malaysia, our outcomes for breast cancer is not as good as our neighbors in Singapore. And of course, the best outcomes globally is Japan at 88.9% 5-year relative survival. So we are at about 66.8%. And often people ask, you know, what's wrong? Is there really no treatments in Malaysia? Why is our outcome so poor? So back to our biggest effect of why our outcomes are so poor is because many patients are presenting at advanced stages. So you can see that people who are diagnosed at stage 0 will achieve 100% survival rate. So this is a 5-year overall survival rate. And in stage 1 is about 98%. So can you imagine stage 1, that means something you can screen and you can detect, the outcomes can be as high as 98% survival rates in 5 years. And for stage 2, which is the most common cancer being diagnosed with people with symptoms, the survival rate can even approach up to 90%. It's about 88%. And stage 3 and stage 4, as you can see, will become much less. Okay, although we see that stage 3 and 4 has become much less, I would say this the outcomes is really temporal in nature. So I think nowadays you can see with more effective treatments and less toxic treatments for metastatic disease, more and more people are living with metastatic disease as a chronic form of disease. Okay, so if we try and see, okay, is there a report card somewhere to see where we are? So there was a white paper published by the Economist recently, last month actually in September, on the impact and opportunity on the case for investing in women's cancer in Asia Pacific region. So Malaysia actually did quite well. So we were moderately high in the policy and planning aspects, prevention and screening, diagnosis and resource capacity, treatment and access, awareness and education. However, why is our outcomes not as good as what we think our capacity is? right? So if we compare ourselves with the countries in the region, we are all green. But of course, we could do better. And you can see Thailand is actually doing very well in prevention and screening. Okay, so I think at the moment we are apparently comfortable, not so bad, not so great. But however, I think most of us want a better future for our country, isn't it? So if you look at the age standardized incidence rate and the age standardized mortality rates, and if you compare it among the region, yeah, the incidence is actually moderately high. We are second to Philippines, right? And then, of course, if you look at the mortality, we are actually, from the figures here, we actually have the highest, unfortunately, compared to the region, right? So unfortunately, we are still known to have poor mortality rates compared to our neighbors. And if you look at this table, it's just projections of changes. So we are expecting a definite increase in incidence. And if we don't sort out ways of actually improving outcomes, our mortality rates, again, and you can see it's not just mortality rates, it's premature mortality, because half of our women in Malaysia are still diagnosed less than 50 years old. All right. So this is what we know. Late stage representation is a key barrier to survival for most cancers in Malaysia. So you can see, if you think breast cancer is bad, where 41.3% of our patients present in stage 3 and 4, look at lung cancer, 75 to 88%, and colorectal cancer at 63.8%. And cervical cancer, you know, and then now we're all going towards eliminating cervical cancer, is still about 38.5%. Okay, so but this data again is a bit dated, it's up to 2016. So the sad thing in here, of course, lung cancer, sometimes we are not able to screen in a more effective manner in our country, because even in India, when they started looking into whether they should do these low-dose CT scans for lung cancer, they found too many false positive rates, because we have a high incidence of TB and all that. So in India, the false positive rate was something like 80%. So we will have people stressed out after doing low-dose CT scans. So in Malaysia, it probably be the same. But I suppose more targeted screening to people who are high risk, that means people who are chronic smokers and all that, should be done. If they have money, because the government doesn't provide this, okay? But the more sad thing here is the other 3 cancers, because these 3 cancers are screenable. Colorectal cancer can be screened by the annual IFOBT, fecal occult blood test. And breast cancer can be screened using mammograms. And cervical cancer can be screened by using HPV testing. So the issues also is not just about advanced stage representation. We know one of the main reasons for this problem is actually delay in diagnosis. So there has been studies, I think one of my PhD students, she's a lecturer in USM now, showed that actually we can even see, even though the median dates of diagnosis interval in 6 public hospitals is about 24 days, which is not bad. But you can see that the range can range up to 9.3 months. So this is something that we need to figure out, how to really make sure that our diagnostic intervals are kept to the minimum, as well as our treatment intervals. That means when you start the treatment should be within a period of 30 days. So here is about 21 days, which is not too bad. All right. And of course, the final one is, of course, access and financial toxicity. I think everybody knows that we can go into financial catastrophe just with the diagnosis of cancer. And you can see from this total expenditure health report from the government shows that 35% overall actually pays out of pocket, you know. So that means we don't use the government facilities, we don't use our private insurance. Private insurance is only 8%, by the way, over there. And a lot of people are actually spending out of pocket. And there was a study back in 2012 that showed that in the Southeast Asian region, 75% of cancer patients will face financial catastrophe within the first year after diagnosis. And in Malaysia, that data was further looked into, shows that 51.4% of the cancer patients in this study fell into catastrophic out-of-pocket expenditure. And you can see there, even for people who access private hospital, 72% actually will face catastrophic out-of-pocket expenditure. And out of those people in the private sector, actually 67% of them have insurance. So we must think very clearly about how we're going to insure ourselves, because you can't wait for social insurance to happen. Even though we have universal health coverage, there are many access issues towards universal health coverage. All right, I thought I'll just touch on the risk factors, because I think for general practitioners, your patients always want to know whether they can modify their risk for breast cancer. So we know that risk factors can be modifiable or non-modifiable. So unfortunately, the most common risk factor that we know is age, and age is not modifiable. Ethnicity, I think in Malaysia, we can see the difference in incidence. So it's more common among the Chinese and Indians compared to the Malays. And family history, so you cannot change, right? The menarche, menopause, nulliparity, okay, and also history of precancerous lesions, so atypical ductal hyperplasia, lobular carcinoma in situ. You can't change all this, okay, but we can change the modifiable risk factors. For example, obesity, level of physical activity, amount of alcohol consumption, and exposure to exogenous estrogen progestin. This is more on the HRT and the OCP exposure. So these are the things that you could do. So I would just mention that sometimes alcohol consumption is a little bit guarded issue. Maybe we don't face that high amount of alcohol consumption, but then we see Pink October being celebrated by wine bars, asking people, selling some, wine, I don't know, Jason, but essentially we must know that alcohol causes cancer. So that's something that I think somehow Malaysians are not really aware about that. Okay, and one thing about family history, it's always known to people are thinking that, family history is probably the only risk factor that I need to be worried about. So when they have cancer and they don't have family history, they're very surprised. So actually 70 to 80% of our breast cancer patients do not have a family history. So I think we must always don't think that if you don't have a family history that you are not at risk. So this is something that I thought I'll put up. And if you want to know whether there is some hereditary risk, you can look at the family history. There's some sort of patterns that you can see. The cancers are usually happening at the young age. More than one relative will have a type of cancer. So or that family member has multiple types of cancer, or it can have in both of one organ, that is bilateral breast cancer, or people with atypical cancers for males, for example, breast cancer. Okay, so I'm going to put up here what the Malaysian clinical practice guidelines, the guidance in terms of finding people to test for the BRCA1 and 2 gene. So nowadays we are looking more into the cancer type criteria rather than family history, because now we know, right, family history is not a very common thing really. So if anyone has ovarian cancer, epithelial non-mucinous ovarian cancer, they should go for testing. Okay, breast cancer in patient diagnosed 45 years and below is also a criteria. 2 primary breast cancers, both diagnosed less than 60 years old. So this means that they could have bilateral breast cancer at the same time, or they can have a metachronous cancer. That means they have one cancer in 1 year, then another 3 or 4 or 5 years later, they have another one in the other breast. Okay. Triple negative breast cancer diagnosed 60 years and below is also a criteria. Male breast cancer is a criteria. Breast cancer plus parent, sibling, or child with any of the above criteria. So this is the original family history type of criteria. So this testing is cost effective because if you follow this criteria, any one of these criteria, the uptake, the positive rate of the BRCA gene would be about 1 in 10. So if we are indiscriminate, then it will be probably like 2 in 100. If you are indiscriminate, you just test all the breast cancer patients. So the uptake is not going to be cost effective. But if you follow this criteria, it will be quite cost effective. 1 in 10 might actually have the gene. Okay. And then I put this up, but I'm not an oncologist and I don't enjoy seeing all these very complicated slides. But essentially, you must know that nowadays, even having that BRCA gene will help determine the types of treatment you might have at the point of diagnosis. That means you may be suitable for a drug called olaparib. These are PARP inhibitors. These are targeted to the BRCA carriers. And this can be used even in curable breast cancer. Many years ago, it was used for metastatic breast cancer, but now it is also used in curable breast cancer, which is we call adjuvant treatments. Okay, right. So, okay, this one, I think I can skip this one. But if you want to know more about risk factors and how to help your patients know how to reduce cancer risk, you can go to the World Cancer Research Fund International website and you can get these recommendations. These are all evidence-based recommendations. So you can see that be a healthy weight, be physically active, eat a diet rich in whole grains, vegetables, fruits, and beans, limit consumption of fast food and other processed foods high in fat, starches, or sugars, like what we all like, right? Okay, and then limit consumption of red and processed meat, limit consumption of sugar sweetened drinks, limit alcohol consumption, do not use supplements for cancer prevention. I think that is a very, very important message, I think, especially in our community who really love to take all kinds of supplements, right? And for mothers, breastfeeding is one of the things you can do to prevent breast cancer. But even saying that, I have met a patient who had cancer when she was about 70 years old. She had 20 children and she breastfed all of them. So still, you know, it is just a risk factor, but it doesn't mean it is 100% protection, right? Okay, and of course, the last one, if the patient is a cancer survivor, follow the same recommendations. So I think if we even just able to recommend this to our patients, we can really improve outcomes in terms of risk. Okay, but again, cancer risk is not something you can prevent. Most of the time, cancer occurs in a very random manner. So that is why you know, we can't really pinpoint something that can completely prevent cancer, but we can try to reduce risk of cancer. Okay. So I've already talked about a bit of risk assessment. Like this is how you assess risk in the clinic. So if you have a patient who you consider might be high risk based on their criteria just now, maybe they have similar criteria as the BRCA testing criteria, the family history criteria. Okay, then you might think a bit differently in how you want to screen your patient, or you might want to refer them to maybe a breast surgeon or okay, but actually primary care physicians can take care of high-risk individuals and how to manage their risk. Okay, we've talked about the challenges that we see. So what would be the strategies to detect cancer early and ensure that people get their treatments early? So I would like to first start off with at least understanding the two concepts of early detection. Okay, so when we talk about early detection, people always think it's about screening. However, we know that, I mean, I already mentioned that in stage 2 breast cancer, survival rates can be as high as 88%, which is, you know, even if you detect a lump, which is 2 centimeters and below, you can even ensure that the patient may actually have very good survival rates. So what are the concepts? What are the differences in these concepts? So it's all about symptoms, right? So if we do screening, it means that the person is asymptomatic. So you can see that in an asymptomatic patient, we're hoping to achieve detection of very small lesions, could be precancerous, and breast cancer screening is actually one of the things that have been proven to improve survival rates. So reduction in mortality in all the mammogram studies in the Scandinavian countries in the 90s have shown that screening mammogram have improved outcomes for breast cancer patients. Okay, so when there's symptom onset, we are now trying to diagnose people with early breast cancer when they are symptomatic. So that is what we call early diagnosis, because we know early diagnosis works in breast cancer. So it's not just screening, but also early diagnosis, by actually ensuring that whenever a patient has a symptom, and especially an early breast cancer symptom, like just a breast lump, if you can actually get that person diagnosed at that stage, you can actually even have very good outcomes, right? And another thing about being cost effective, can we really afford screening so many people to detect? Okay, so the usual numbers given is like, in 1,000 women, you should be detecting about 5 cancers. And that is what would be cost effective in the eyes of policymakers, right? But is that something we would have in our country, you know? And is our screening program, what we're doing now, the opportunity screening, is it really working? Because you need to actually do the screening, not just once in your lifetime, but in a very periodic 2-yearly type of fashion. Then you can actually detect these cancers at an early stage. All right. And if you have someone with a small breast lump, can we ensure that we actually get them diagnosed quickly? Do they have access to biopsies? I mean, we know even in the private sector, the biopsy, the actual cost can be up to sometimes 5,000 ringgit. Okay, maybe some places about 3,000 something to 5,000 ringgit. So this is not cheap. So not a lot of people can pay out of pocket 5,000 ringgit to get themselves diagnosed. So we need to think about how we can actually bring about UHC in Malaysia for diagnosis. All right, so I would like to show you this WHO Global Breast Cancer Initiative Implementation Framework that was finalized last year and was disseminated last year. So this is a very important document, because this is a document that is compiled with evidence. That means their targets is really to improve survival rates. And because they have done all the searching of evidence, they have now found that 3 pillars that actually can improve the cancer outcomes. So the first pillar is health promotion and early detection. So remember, they said early detection doesn't mean it's screening, okay? And then you have pillar 2, which is timely diagnosis, meaning we need to get people with symptoms or with abnormal screens diagnosed, okay? And they have a target of 60 days, right? And then for pillar 3 is comprehensive breast cancer management. That means the patient will be able to access comprehensive treatments. All right. And then the targets here, you must remember, is 60, 60, 80. So we have many targets. I think even for cervical cancer, if I'm not mistaken, is 90, 90, 90, something like that. But for breast cancer, is 60, 60, 80. So 60% of our patients should be diagnosed at stage 1 and 2. And pillar 2 is timely diagnosis. That means evaluation, imaging, tissue sampling, and pathology is completed within 60 days when the patient presents to the health center. So the problem here is sometimes our patients' symptoms. If we look at, I think the median symptoms patient present, it is actually quite long, you know, it's about 30 days, right? But then if you look at the range, it can go even to years. Okay, in our study just now, I think it was about 8 years or something like that, if I'm not mistaken. So, and it can be possible, okay, because some tumors are so slow growing that they can present at that stage, you know, because they only have a problem when there's an ulcer, but that lump has been there for the last 8 years because it's a very slow growing tumor. Okay, so one of the other things this group did was they looked at all the causes and effects. What are the problems? And if some of you have worked in the hospital and you have heard about quality improvement projects, then you will know this fishbone diagram, isn't it? So they have looked into all the issues that can be the cause of problems to early diagnosis. So I don't think you can see the slides very well, but one of it, when you look at the first pillar, which is early health promotion and early detection. One of it is lack of training among primary care providers on how to recognize signs and symptoms of breast cancer, lack of training among primary care providers in clinical breast awareness. Patient must travel through multiple levels of healthcare system before accessing diagnostic services, late presentation of women with signs and symptoms at the primary care stage, poor transfer of information to patient and between the higher levels of health system. So for primary care, one is sometimes, because the last time you heard about breast cancer was during medical school. So I did a doctorate, I think 10 years ago, and I was trying to see what was the cause of why these women are presenting with very advanced disease. So it was a qualitative study. So there was a lot of issues in primary care providers not recognizing symptoms. In fact, among the patients that I interviewed, a nurse, actually she's a nurse, she thought she had to wait until she has peau d'orange before it's breast cancer. So she actually had a breast lump, but she didn't think it was a breast cancer. And then she showed it to her doctor in her clinic kesihatan. The doctor also said, oh, this one, is benign, is mobile, so don't worry. So she didn't know. Also, she said, okay, the doctor also said it's okay. So she waited and waited until it became advanced disease before she presented to the hospital. So I think this is nothing to be ashamed of, because I think at the point now, a lot of our general practitioners, the only exposure they have had is during medical school. And so I think it's very important that we stress the importance of knowing that just a breast lump could be a breast cancer. And we are trying to detect them at stage 2 or stage 1. That means anything less than 2 centimeters would be the best. Anything that you can feel as a lump should be investigated. And I will go into more details later. So you can look at the secondary causes. So the main underlying causes I mentioned, the secondary causes is actually low uptake due to lack of confidence. So I think this is seen because we had done some training programs for our community nurses last year and the year before. I mean, this year and the year before. And one of the things they mentioned, these are nurses working in community clinics like LPPKN as well as Ministry of Health. They do all kinds of screening programs, but they are not able to communicate confidence to the patient that the patient should go ahead and get that biopsy, go ahead and do that colposcopy and biopsy, go ahead and get that colonoscopy. So the confidence is important. I think it's the same also for general practitioners, because sometimes, when you feel a lump, even for me, when I feel a lump, is this really a lump? Okay. And I know some of the GPs do have an ultrasound in the clinic. There are pros and cons of having this ultrasound. Really, it can help you determine, okay, is this a cyst or is this a solid lump, so that you can be confident to refer, right? But I have to say that you don't need to be confident to refer, because if you feel some abnormalities, that patient will need further investigation. So she will need triple assessment and all that. And remember, that is no longer screening. That is already diagnostics. So diagnostics, you need to do it within 60 days. So I would say if you feel a lump and you're not sure, maybe you want to see her in 2 weeks' time just to see, okay, maybe it's her periods. A lot of women before their periods, they get very lumpy breasts, and that lumpy breast may actually disappear when she gets a period. So you can do that. You can review in 2 weeks. Or if you feel that you're not sure, any woman with a breast abnormality should be investigated. Doesn't matter what age group. Okay, so I will go into more details later. So if you look at this is from the WHO implementation framework. So they've done the research. They can show that if we don't do anything, okay, and when they model this using data, they look at if there's no early detection, no cancer treatment, definitely you will have more breast cancer death, obviously, right? But the most greatest impact is actually early detection plus cancer treatment. So I think that is what we need to do, early detection. And remember, early detection is not just about screening. All right, so they've done the calculation, and what they are aiming is a 2.5% reduction in mortality in the next 20 years. Okay, so they are expecting a reduction of 2.5 million breast cancer deaths in 20 years. So by using these three pillars, I hope all of us will be able to work together, primary care, the breast surgeons, the oncologists, and everyone, to make sure that we actually fulfill this 60-60-80 for our country at least, yeah? Okay, so the elements of successful, you can read more about it in this document. It's quite easy. You can just Google it. Okay. All right. So when we say about this pillar 2, we always want to target people to get their diagnosis done within 60 days. So that means we have to work very hard with the primary care doctors, right? Because when primary care doctors sees the patient, refers. So that referral should take about 2 weeks. It shouldn't be delayed. And then when the surgeon, usually in Malaysia, this one also I must say, a lot of people are very confused about who diagnose breast cancers. So the doctors that diagnose breast cancer is the breast surgeon or general surgeons. They are not the gynecologists. Because we have had patients who spend some time with the gynae, about a month before they actually reach the diagnostic, the breast surgeon or the general surgeon. So I think we need to make sure all the primary care doctors know, if you need to solve a breast problem, refer to general surgeons or breast surgeons. Because in Malaysia, we are not like the Europeans. Europeans, they do both breast and gynae. But in Malaysia, we're like the British people, right? So we do mainly in the general surgery and breast surgery sphere. Right? So I don't want to go into too much detail with all this very complicated looking figures. So you can actually go and look at it later on your own when you get hold of the document, right? So this diagnostic interval is something very important. So you can see there's clinical evaluation, imaging, tissue sampling, pathology. So even in the hospitals, we have problems with this. Okay, because we need a lot of multidisciplinary group of people to actually make the diagnosis. So I would strongly suggest to our colleagues out there, primary care doctors, to send to places where you know can get the diagnosis done quickly. So I would say National Cancer Society has a very good service because they actually have a breast radiologist, and then they even have a doctor there to actually to break the news to the patient, you know. And a lot of the breast centers with breast surgeons would have a good setup, because breast surgeons, they're trained to make sure they get this done quickly, right? So for general surgery side, it can be quite difficult for them because they are doing multiple types of surgeries. They have to focus on all the acute services. So please look out for hospitals that have breast surgeons, even in the public sector. So like PPUM, PPUKM, PPUPM, PPUITM, all the university hospital would have breast surgical services. And you can also go into HKL. HKL has a very good breast service. Selayang has a breast surgeon. Where else? Putrajaya, of course, they are a breast center. Okay, so these hospitals are the common cancers that can do things quickly. HKL, Putrajaya. So if you can refer them there, go ahead. But Selayang is the other one. Selayang has a breast surgeon. But the other hospitals, some of the smaller ones may not have. But we know that generally, most of our cancer patients are diagnosed by general surgeons. So we are trying to also help them improve their care, because they need to organize their MDTs and all that. So that's something in progress. But really, if you want something done quickly, look for hospitals that have breast surgeons. Okay. All right. Okay, not going to go into too much detail. So what does our clinical practice guidelines say? So we talk about WHO, right? How about the Malaysian guidelines? So our Malaysian guidelines are recommending screening mammogram for women above 50 to 74 years old. Okay, for women of high risk of breast cancer, where there's no genetic variant that has been identified. So that means these people will have a very strong family history most of the time. That's how you detect them. They will have first degree relatives at least, I mean, usually we call we use this 3-to-1 moniker, okay? So 3 people in the among the first or second degree relatives having breast cancer. Okay. The second one is 2 first or second degree relatives that will have breast cancer, but one of them must be less than 50 years old. Okay. One is where you see the male breast cancers, ovarian cancers, bilateral breast cancers. If you have any of this type of family history, then they are considered high risk. So by knowing that they are high risk, you can even consider doing screening mammogram 30 to 39 years old, because some of them, the family member may have had the cancer at the age of 35, for example. So there is no harm using screening mammogram. Of course, you may want, if you have access to MRI breast, that may actually be a better option, because mammograms are not so sensitive in young women when they are having very dense breasts. Okay, but this is what the recommendation is. These high-risk women should have mammograms annually between 40 to 59 and biennially from 60 onwards. Okay, because they are considered, most of them may have their cancers at a more early age. Okay, this is our Malaysian guidelines. Okay, they have gone through all the stakeholders and looking at all the evidence. So this is what is recommended. So for people with the BRCA gene, annual MRI is offered between the age of 30 to 49, annual mammogram from 40 to 69, and 2 yearly memos from 70 onwards. So you can actually access this document. Again, just Google it, you will find it, and you can download the PDF, okay? And one thing that we have here is the referral pathway. Patients with any of the following conditions should be referred early within 2 weeks to breast or surgical clinic for further evaluation. Women aged 35 and above with signs and symptoms, high-risk group with signs and symptoms, patients with clinical signs of malignancy. So essentially anyone with a breast lump and they're above 30, okay, 35, this one is actually, there was a lot of debate, what should be the age to refer? So I would say if you have a woman who is above 30, definitely you need to get them done quickly. Less than 30, remember, they may also have cancer. It's quite rare, but they may have cancer. So I think anyone who needs a diagnosis, remember, it's 60 days. So you can also send these women, the younger women, for diagnosis so that they get their diagnosis within 60 days. Most of them will be benign. Okay, but sometimes you might miss that one lady, young lady who actually has breast cancer and does not have the family history. We have seen that type of patients also. So the general rule here is to get people diagnosed within 60 days. Okay, so there are many, many things that you will be able to find in inside this document, like how we use the BIRATS classification. Okay, so you see, the problem sometimes in Malaysia is that not all our radiologists will report the BIRATS. The BIRATS is a very important way of communicating with the doctor seeing the patient. Okay, so for example, if the patient gets a description of BIRATS 0, that means that mammogram is incomplete. We need to supplement that with an ultrasound. Okay, so if you have a patient with a breast lump who actually you can feel a lump and she goes to the mammogram, you send her for a mammogram, they've reported it as 0, BIRATS 0, or even BIRATS 1, which is normal. Okay, that woman has a lump. Because we must know that mammogram, the sensitivity is about 80%. You may miss lumps that are not seen on mammograms. So anyone who has a symptom, even with a normal mammogram and ultrasound, needs a clinical evaluation by a breast surgeon, because we may be able to even do MRIs or even proceed to do biopsies, even though the mammogram and ultrasound is normal. This is very commonly seen in lobular carcinoma. Okay, lobular carcinoma, if you remember your young medical student pathology days, how they describe the cells is red Indian filing. I think now tak boleh lah, macam very racist kan. But basically what they see is little cells that line up rather than form clumps. It's not like a clump of cells which is invading into the tissues. It's like, like a row of cells invading out into the tissue. So they don't really form lumps. It's just that the breast becomes firmer. So I've had a patient, one of the people I met in the some discussion in the public awareness talk. So she said, my cancer was strange because her breast at the age of 60 was younger when her breast was 50. So she's wondering why is her breast more perky? And this poor lady has had a memo every 2 years for the last 20 years since her age of 40. Very diligent doing her memo, but it was not detected until it was stage 3 because it is lobular. Can't be seen on memo, can't be seen on ultrasound. It's just that she feels her breast is different. So that type of patient, please refer to a breast surgeon. They will probably have to do further tests, maybe MRI, maybe even biopsy, blind biopsy sometimes. Okay, so please refer to the specialist if you see someone like that. So going back to the BIRAT, so this is a very important tool for general practitioners, because if you want to do and provide screening for your patients, you should be able to read and understand the BIRATs, because the BIRATs will tell you what to do next, right? Because we are not special. Even for me, I would not look at a mammogram again if the radiologists have reported it, because the radiologist should be the one giving the recommendation. And what we see on our screens in clinic is not the same as what the radiologists see on their diagnostic monitors. So it's very different. So please, I hope that our radiologists will be more responsible in actually putting down the BIRATs classification, because we as end users need to see. Okay, but again, I always look at the ultrasound mammogram just to be sure, because sometimes you must remember that our level of specialization may not have as much volume. Like a good radiologist would have to have a volume of 300 mammograms a year to be able to be good at screening. Not many of our radiologists have that opportunity. So when they report, sometimes we also need to double and have a look, okay? And sometimes when they come over to my place, I also will consult my radiologist. Maybe you want to have a look. I'm not sure the images look like this, So always be careful, because sometimes we may miss things. Okay, so back to the BIRATs, you can see there's 0, 1, 2, 3, 4, 5, 6. 6 is when the diagnosis is already known. But you can see that when it's BIRATs 4 and 5, that means a biopsy is required. Okay, BIRATs 3 is probably the most common ultrasound finding. And this is the problem sometimes, because you need to repeat the ultrasound in 6 months for a duration for about 1.5 years to 2 years to make sure that that lesion is stable and benign. Okay, so and I want you to focus on the second column. Even though they have categorized it as 0, 1, 2, 3, 4, 5, 6, you can see that the likelihood of malignancy is there. Okay, so for example, BIRATs 3, the likelihood of that benign lesion being cancer is less than 2%. And then for BIRATs 4 is 12 to 25%. So it's not 100%. So a lot of women, when they have BIRATs 4 lesion, they get so stressed out, So we have to tell them the chances are, there's still a chance that this is benign, okay? And then for BIRATs 5, it is highly suggestive. So the percentage of it being a cancer is about more than 95%, okay? And known malignancy, of course, is already been biopsy, so it's 100%. Okay, so the next step in evaluation is what we need to think about. As I mentioned, BIRATs 3 is the one that you need to go to 6 monthly imaging. Sometimes the BIRAT is also reported for mammograms. Sometimes a mammogram is reported as a BIRATs 3. So that means that patients need a mammogram on that site in the next 6 months. So for BIRATs 1 and 2, usually you go back to the routine screening, which is every 2 years for people with average risk of breast cancer. Okay, so there are many things here that I don't think I want to go into too much details. But I think what is important is that people recognize that cancer treatment is not going to start with just surgery. Okay, so we will go into more details later. And even in the recommendation, there's something about fertility preservation, because young people, when they're diagnosed with cancer, the chances of the chemo affecting their future fertility is high. So there are options for actually freezing their eggs before their chemotherapy is there. Okay, and then of course familial breast cancer, we also already mentioned just now that you can actually look out for these people and do intensive screening, or even offer risk reducing strategies. Okay, I think we are now at about 1 hour, right? So maybe we can stop here and maybe take some questions.
There's actually one question that came in on our YouTube channel actually. They were asking us, so Prof. Aishah, what is the difference in terms of cost for treatment for early versus late stage cancer? What's the difference in terms of cost? It means, let's say I'm an early stage 012, how much is that estimated total cost for treatment? And before, what's the estimated total cost of treatment?
Okay, I think this is a very important question. So the reason why the disease, when the advanced cancer treatments become expensive, is because the treatments are meant to control the disease. So for example, someone with stage 4 breast cancer, the treatments can be used forever and ever because you need to control the disease. And unfortunately, for many of the patients with stage 4, they will succumb to the disease eventually. But nowadays, we have many new treatments. So for example, the what do you call that? The CDK4/6 inhibitors with hormonal therapy have shown that they can push the survival rates to even more than a year after the usual outcomes, you know. And also these new drugs like the antibody conjugates, which have shown to improve survival rates by the margins at 1 year plus. Okay, never been heard before, right? So the treatments can be expensive in metastatic setting because not just they are going to go on treatment forever and ever, but they are also going to have newer treatments. Newer treatments would mean these drugs are still very early in the marketing phase. That means they are patented, therefore there's no generics yet, there are no cheaper options. So these drugs are usually, when these new drugs come out, they may be about 15 to 25 to 30,000 per dose, you know. So these drugs are expensive. So that is why we would like to stress that we should try and get patients come at a very early stage. And if you do screening mammograms and all that, you may find that the treatment is just surgical treatment, not chemo. You don't need, maybe you don't even need radiotherapy. You may not need other treatments. So that is why early treatment, I think generally, probably in the private sector, it would probably cost, if you have surgery just with, let's say, without reconstruction, it will probably cost about 15 to 20,000. But with reconstruction, can cost you maybe about 60,000. Okay, with the implants and everything. And then if you're going to have chemotherapy, it might go between 30,000. And then remember all those new drugs, the olaparibs and these new things may add on some more treatments. So I think generally for people with who intend to detect early cancers, maybe your insurance should cover at least, you know, maybe about, I don't know, maybe 120,000 to 200,000. Okay, but if let's say you're diagnosed at a later stage and you require all these new drugs that can easily cost 30,000 every 3 weeks for a year or 2 years or whatever years, you know, as long as it works, you might need a coverage of 1 million or something like that. Okay, but in the government sector, there is treatment. So don't get the wrong impression that the best treatments are always in the private sector. The public sector actually provides very subsidized initial some drugs that we, you know, like the standard drugs that we use, chemotherapy, is very well subsidized. So just now I mentioned maybe it comes to about 30,000 for the usual type of chemo, the basic chemo in private sector. It might cost you only like every time you go for blood tests, you know, it might cost you maybe like 80 ringgit per cycle, because that's where they do the blood test. You don't have to pay for the drugs. So remember, there's always options in the public sector. And the diagnosis also can be done in the public sector. So most of the government hospitals, the Ministry of Health is very, very much subsidized. Maybe you are paying a minimal fee. I think maybe even if you get admitted, your bill is not going to go beyond like 200 ringgit or something like that. In PPUM, we are a bit expensive because of we are from the Ministry of Education Hospital. I guess a basic diagnosis in PPUM will probably cost you about 1,200, because remember, when we do biopsies, we do the biomarkers. These biomarkers can cost a lot. The lab test is costing a lot. So even in PPUM, because of this problem, we have a B40 diagnostic fund. So if anyone who is in the B40 group, we can put them through a fund that we have done a lot of fundraising for. And I think NCSM also does a great job in making diagnosis quickly. I think it's a wonderful community-based diagnostic center, and I wish that we have more of these type of centers around the country that can ensure very fast diagnosis. Because once you are diagnosed, you get sent to a public hospital. Usually the treatments are pretty fast. The diagnostic process is sometimes the one that a lot of queue and all these issues. I hope that answers your question, Jason.
Yes, that actually answered the question fantastically. So, like, early stage costs about 20,000 each, 50,000, but then later stages cost up to what, 200,000, 300,000, up to 1 million as well. So yes, thank you so much, Prof. Aishah, for answering the question. But yes, what you said is actually very true. We always find out that the screening and the diagnostic part is the one that takes the longer one. Once the diagnosis is there, no one hesitates anymore. Public, private, all jump in straight away. The treatment gets done very fast. And Prof, there's actually one more question from Dokuti, from a Dr. Swaran. Just one quick one before we go back to the slides. Yeah.
Okay.
Prof, your view on young ladies undergoing breast implants for beauty purposes and their risk of developing early breast cancer at later future time. I guess what she's trying to say is, with this whole advancement of beautician nowadays, a lot of breast implants are happening, whether it's legal or illegal. With a lot of things are not too sure, like silicone injections, and I'm sure you see a lot of that.
Yeah,
The risk of it getting cancer, how?
Yeah, I think this issue is very sad actually, and we've heard a story of someone dying from breast injections, isn't it? I think somewhere in Johor recently, and this highlights like the worst thing that could happen to a patient. But unfortunately, there's so many people currently attending breast clinics because of the complications of these aesthetic procedures. So I would say you have different types of reconstruction. Not reconstruction, sorry, implants or enhancement, right? So in the aesthetic medicine sphere, I think there are very clear rules about who can perform what procedures. And I think this is through the College of Surgeons. So that patient, that doctor who's actually performing this aesthetic medicine procedures has to be certified by the College of Surgeons plastic surgery chapter. Okay, so there is a clear. So I think sometimes people don't know, that's why they just indiscriminate, just go to any clinic for their aesthetic needs, right? But there are also these other nak panggil apa, black market under the ground, but not so under very much out in the community, that a lot of advertisements for them to go. So we've heard about stories, like I had a patient who went to a terrace house. It was a house, and a beautician actually did the injections for her. So, okay, the fact that whether they cause cancer, okay, that link, unfortunately, there is no proof that it can cause cancer. But what the problem is, in the future, when the woman needs to go for screening, it will definitely screw up the images. So like the mammogram will look like a snowstorm. Okay, we've had, injections is nothing new. I've seen some women in their 70s now coming with implants, coming with injections. And when they need to have, let's say, they have a breast problem, where we have to do the triple assessment, all these images are going to be very difficult. So in the end, we end up with very expensive tests like MRI. So the problem is not about causing the cancer, it can mask the cancer, and these procedures cause a lot of complications. So I think to answer Dr. T's question, I think it doesn't cause cancer lah, but it might actually increase the risk of missing cancers. when they go for screening or when they have a breast problem. The other thing is there has been some reports of different types of cancer related to implants. So I think the plastic surgeons would be better to explain this, but there is a type of leukemia that can happen from the textured implants of the past. So when women undergo reconstructive surgery for breast cancer, they find, some people actually have a higher risk of having this type of leukemia, and that association has been proven. So that type of implant is no longer used. So I think the implant is, we call textured implant. That means the implant doesn't have a smooth surface, and somehow it had increased the risk of having leukemias, a certain type of leukemia. Okay, I hope that answers the question.
Yes, like I told you at the start, you sure gonna get a lot of questions. But there's actually a second question, but I think just to add in is
okay.
I think it's BIA ALCL, breast implant associated lymphoma.
Yes.
I saw a case in coming to NCSM when we did the free mammogram for the patient. The whole thing stormed out. I had to explain to her we need to do MRI. She's like, why? Oh, because you had an implant last time. Oh, then she forgot she had an implant. So yeah.
Yeah,
So
very difficult to detect. Okay.
One more question, can I, Prof. Aishah? There's one from
please.
Okay. So Dr. Humaira from Dakuti was asking, her patient's mother passed away due to pancreatic cancer. Her mother's sister developed breast cancer at 50 years old. Her patient is actually 56 years old, and her ultrasound showed a complex cyst. So the question she has is, do we need a yearly or 2-yearly mammogram for this complex cyst?
Okay, complex cysts. Okay, the thing about complex cysts, there are two types of, there are simple cysts, complicated cysts, and complex cysts. So, complicated cyst is just a cyst with fibrous strands. So it's almost like you have a circle and then you have like a, like a strand inside that cyst. But our radiologists, they like to even report that as complex cyst. Okay. But if you look at the way how it's supposed to be described, complex cyst is a cyst. That means something that you can draw a line around that has something inside it, like a fleshy mass within the cyst. So complex cyst is something that we are always worried in terms of having a very rare cancer called papillary intracystic cancers, carcinoma. So this type of cancers, we need to biopsy. I mean, not cancer, I mean, this type of lesion, the complexes with the fleshy material in it, those are the types of cysts that need biopsy. And how we biopsy is using ultrasound guidance. So that is usually given to the radiologist because these complexes are usually very small. So I would say if a lady has complexes and then we've done the risk assessment, she appears to be high risk, right? I didn't get the history. So mother had breast cancer at the age of 56.
So the mother had pancreatic cancer, but the auntie has breast cancer.
Pancreatic cancer, what age?
Not stated here, but the auntie who had breast cancer developed younger than 50 years old.
Less than 50. Okay, so I think with that history, don't forget the BRCA gene is no longer known as HBOC, hereditary breast ovarian cancer gene. It is now known as HBOPP, hereditary breast ovarian, pancreatic, and prostate cancer. Okay, so that means BRCA genes are also associated with pancreatic cancer. So with the family history like this, mom had pancreatic cancer, but if we're not sure how old, but if she was young, and her aunt, maternal aunt, had breast cancer less than 50, would probably put her at a high risk category. Okay, but we do not know if anyone had done the test. Because sometimes, if let's say you have a family history like this and her mother had a gene test, so the gene test shows that she carries maybe BRCA gene, right? Then this lady could actually have a gene test too. And if she doesn't carry the BRCA gene, that means she does not have that risk similar to her mother. Because the chances of transmitting the BRCA gene to the progeny is 50%. So every time mom was pregnant, that progeny would have a 50% chance of having the gene. 50%, the other 50% means she doesn't carry the gene, so her risk is not going to be as high as what a BRCA carrier would be. So for this lady, I think the question was whether she needs screening and whether she needs to have a biopsy. So I would say because we have assessed the risk to be high risk, and then she has a complex cyst, and if it's the fleshy type, not the complicated type, she needs a biopsy. So I would recommend you refer her to a breast surgeon or general surgical clinic. Okay.
Prof. Aishah, perhaps we can continue with the session first, because there are a few more questions, but I think we can lump it together towards the end. Would that be okay, Prof?
Yeah, I think that will be fine. Okay, so now we try to look at, remember just now when we say early detection is through symptom recognition, right? So I put up this slide because I think it's such a simple slide to show the myriad of symptoms of breast cancer, and I think a lot of the doctors would have some exposure during medical school, right? So essentially, the early breast cancer could be the ketolan keras, which is just a lump, as I've been talking about since this morning. And then the other thing is the nipple ulcer or nipple rash, or we call it the Paget's disease, right? So that Paget's disease may be a ductal carcinoma in situ. It may not be an invasive cancer at all, but of course we need to rule out if there are any other associated lumps in the breast. Okay, but when they have anything wrong with the nipple, they should be checked. They need triple assessment again. And if you don't find any underlying lesions in the breast, that nipple rash should be biopsied. So that can be done by the surgical people lah. Okay. And one thing about this nipple areola issues, a lot of women come with areola eczema. Okay. So if it's bilateral and affecting just the areola, I think the rash should be treated and reviewed. So that means you can put her on topical steroids. In 2 weeks' time, review again. If it doesn't disappear, she needs to go and see a breast surgeon or a general surgeon. Okay. I mean, saying that, sometimes eczema, if you have patches elsewhere and then it's bilateral, just the areola, you shouldn't worry that it's not cancerous lah. Okay. But again, I've seen a very rare situation where there was a patient who had both the nipple and the areola complex being eczematous, and it turned out to be Paget's disease. Okay, bilateral. Okay, so never say never. So anytime the nipple is involved, be more wary about referring on for further biopsy and treatment, diagnosis. Okay, so the other ones like lesung pipit ni, what do you call it? Skin retraction, right? This could also mean the skin is involved, but it also could mean that the Cooper ligament is involved. So it could still be very early cancer. Okay. So and then the others, skin thickening, pore d'orange, these are usually late signs. Okay. Having this enlarged veins, usually you can see this in the phylloides tumor type of cancers, where the tumor is very large, the skin is stretched, the veins are usually more prominent, and this type of very large tumors, they don't ulcerate. These are usually what we call the phylloides tumor cancer. Okay, and then of course nipple retraction. These are all signs that need to be investigated. Okay. And don't forget nipple discharge. So nipple discharge, everybody has nipple discharge. So sometimes a lot of women, they are very stressed and anxious because suddenly, I have nipple discharge, So what makes a suspicious discharge is when the discharge is spontaneous, that means it comes out on its own, and then it comes out from 1 or 2 ducts. The nipple has about 20 ducts opening, right? Ductal opening. So this discharge only comes from 1 or 2. Okay, if it comes from many, that one is not suspicious. But if it comes from 1 or 2, that patient needs a triple assessment. So sometimes when we do the triple assessment, we may find this intraductal papilloma just behind the nipple. But again, it could also be a intraductal carcinoma. Okay, so that's why we need to investigate if the suspicious discharge is there. And even if we can't find something on the mammogram and ultrasound, we sometimes proceed to a diagnostic procedure called microdocectomy, where we remove the offending duct and the underlying breast tissue. So that procedure is diagnostic because sometimes you can't find DCIS even on mammo and ultrasound, and they just present with nipple discharge. Okay, so this slide again is to show that if the patient undergoes routine self-examination, that means every time you have a clinical encounter with the patient, I think anyone above 20 attending a clinic should be taught how to do breast self-examination. That means, I think this is not really put into screening guidelines or anything, but I think this is something important. Teaching breast self-examination could be a way to detect their own lumps in the future. So have that opportunity to teach them that if they do their routine self-examination, they may actually be able to detect lumps as small as about 2 centimeters, like our thumb lah, right? Okay. If they do one mammogram, that means, a lot of our patients, they do mammogram only during campaign, the October campaigns, right? And they didn't know that they actually have to do it every 2 years. They thought do it once, prevention, what? Right? We always say prevention. They get the wrong idea. So once they do it, the first one they do it, usually the lump or the lesion that is found is a little bit bigger. But if they do routine mammograms, and that mammogram is reviewed by the radiologist, that means every time the radiologist can refer back to an old film, they actually become better at detecting smaller lesions. So the lesions are usually much smaller. Okay, but of course, if the woman doesn't realize, doesn't know how to do BSE, doesn't feel her breast every month, she may find a huge lump in the end. And this is what we find most of the time. They didn't realize that the lump could be very large. But again, don't, sometimes we always make our patients, a lot of my patients tell me, oh, I saw the doctor's face, the GP's face, and then I felt, oh my God, I think I have cancer. So we must never portray that it's such a negative thing if you find a breast lump. Because whatever we do, they silently absorb all the negative vibes, okay? So we must be positive. We must always tell them, oh, this lump, it could be a non-cancerous lump. But we need to check it, because if we can detect it earlier, it's better rather than we worry and delay, and then finally it will be worse, right? So for a lot of women, breast cyst is the biggest culprit of stress. You know why? Because breast cysts, they can suddenly blow up into like a 3 centimeter lump, very huge, overnight. Suddenly the next morning, how come I have this huge lump? So a lot of women gets very stressed. That's why if you have a handheld ultrasound in clinic, you can just scan a little bit and say, oh, yeah lah, there is a water cyst. So you can sleep tonight, but you still need to see your breast surgeon and general surgeon to make sure it's nothing else. Okay, and I have to say, I use bedside ultrasound all the time because it helps me in my assessment of the patient in the clinic. But I always refer to the radiologist, and I think all of you as general practitioner should tell the patient, I'm doing this, but you might need more scans later if you find something. Because they always ask me, alah doktor, saya dah bayar lah ultrasound tu, kenapa saya kena buat lagi? But we need proper assessment, because the radiologist will do a better job looking for other multifocal disease, as well as the lymph nodes in the axilla. And we need the radiologist report and assessment for our surgical planning. Okay, so please tell your patient, even though you do the ultrasound, they will need another one later on. Okay, so remember we talked about the mammogram. So mammogram for average risk women, we do it once every 2 years, and we can start from the age of 40. But as you know, our CPG says 50 and above. The Americans have rescinded some of their recommendation to 40 and above now, but the Americans are nuts because they do their mammograms every year. So I think we will hold on to the voice of reason, because the evidence is showing every 2 years is adequate for women 40 years and above. Okay, one thing I think a lot of people don't know is, which I missed to talk about the risk factors just now, is breast density. So breast density is something you detect on the mammogram. So remember we talked about the BIRATS classification, 0, 1, 2, 3, 4, 5, 6. There is another density classification, which is BIRATS A, B, C, D. So the A, B, C, D, AB means the breast is not very dense. CD means it's quite dense. So breast density is an independent risk factor for breast cancer. So people with dense breasts have a higher risk of developing breast cancer. At the moment, there is no real recommendation to do further tests like MRI for screening people with dense breasts. But one thing in Malaysia, we have very worried radiologists, anxious radiologists. So when they have dense breasts, usually they will supplement with an ultrasound. See, in America, women had to take on arms to demand for wanting doctors telling them about they have dense breasts and that they are given an ultrasound, additional ultrasound on top of the screening. Because in America, they just do mammogram and that's it, they don't bother. Okay, oh, normal, but actually virus D, But in Malaysia, our radiologists tend to be, oh no, virus D, I'm worried, I might miss something. So they will do an ultrasound. So generally, most of our radiologists would do ultrasound, supplemental ultrasound for virus C and D mammograms if they're not sure. But this increases cost, right? Okay, right. So the mammogram again is done to the MLO view, the CC view. And one thing I think we fail to tell our patients is that the people handling the breast, because during the mammogram it's quite interesting lah, that you need to manipulate the breast to compress it in a way that they can get good images, right? So the woman needs to know that their breast will be handled lah, kan? But it's only handled by female radiographers. This is like something like legislated lah. No mammo service can run the mammogram without a female radiographer. Okay, so we need to tell women so that they're not worried about that part of the issue lah. Okay, and in terms of radiation, the radiation dose is actually quite minimal. And if they look as you can look at this table, this figure, the average annual natural background in the US is actually higher than the standard 4-view screening mammogram. So I think we have to encourage and tell our patients that, the dose is not that great. Because a lot of people are so scared of radiation, right? Okay, so again, mention dense breast is a limitation of mammogram. And then remember I talked to you about lobular cancers. Again, that's a big limitation. And then there's this movement of people, epidemiologists around the world that now says that when we do mammogram, we do a lot of overdiagnosis, which could be true. That means you are treating people based on a mammogram that shows precancerous lesion that might not affect the woman's lifetime. So this question is still being answered. They are doing a research on following up people with radiological and biopsy proven precancers. That means they don't treat them, they just follow up. Okay, so there's a study ongoing with that. So we will wait and see what comes out of that research to know whether we are doing overdiagnosis. At the moment, we shouldn't focus too much on this because we are trying to get people to come early, right? Okay. And of course, compression is a problem sometimes. So give some assurance to your patient they can take Panadol if they want before they do their mammograms. And one more thing is that we need to tell patients about the need of biopsies. Because a lot of people think, when I do mammogram, I'm preventing myself from getting breast cancer. Because we always say, breast cancer prevention, we do screening mammogram. So they thought, I do this, but they didn't know. Actually, it's a way to detect things that are very early. So therefore, they will need some procedures if it is found to be abnormal. So I think that discussion should be held first before a mammogram is ordered. Because a lot of women, when suddenly they find something abnormal, they go underground. I've seen many of these underground women for 6 months, 1 year, they don't do anything because they are so scared. They didn't know that actually they have to go on and do the biopsies. So they went underground. Okay. So I think they have to be made aware about what needs to be done if they are found to be positive, right? Okay, so we know there are benefits. We know that the early detection definitely will have high cure rates. And a study we did in our hospital, we do, I guess it's worth it. If we do opportunistic screening. That means we are doing it in people who don't really have risk factors, but they're not on the part of a program. We can detect 5 in 1,000. So it's not terribly bad that we are doing opportunistic screening and not doing a good job lah. So 5 in 1,000 is cost effective. It is probably worth doing the mammogram. Okay. Targeted screening is when they have family history. So the outcome is 125 cancers in 1,000. This is in PPUM. So it's not too bad. Okay. And in our study, from screening, we found that early stage breast cancer was about 84.6%, right? So sometimes, you know, even people who go for screening, sometimes they have advanced disease, you know, lymph node involvement and all that. So I guess it's not perfect. We all know that sometimes patients even with tiny lumps already have metastases. All right, so this one I think we don't have to go into too much detail, but I thought this is something very interesting, and I think for general practitioners who have a very strong, like follow-ups with your patients, long-term follow-up with your patients, you can even offer them clinical breast examination. So there was a large study in Mumbai, India, involving something like 34,000 women randomized to 2 groups. One was given clinical breast examination every 2 years. And what they found was there is a 30% reduction in mortality for women above the age of 50 just by doing clinical breast examination. So I think if you have a clinic and you have a very follow-up of people with diabetes, hypertension, right? And they come to you like for the last 4-5 years, you can offer them screening clinical breast examination. So I think the PERCA B40 thing, where they offer CBE, is actually a good thing. Right? Even if you can't afford the mammograms, you know, the B40 can't do it, or actually there are subsidies and they can access it. She said they don't know. But even by clinical breast examination, you can reduce the mortality by 30%. Right? And just now, as you mentioned, the breast awareness, even though breast self-examination is not in the guidelines, you know why? Because there's a supposedly a study that sort of concluded that BSE is useless. But actually that study, if you look at the design, it was on BSE education, all right? Not BSE practice, right? It was done in China, huge numbers, didn't show any improvement in survival in the group that they taught BSE, okay? But then the median size, even in the control group, was like 1.8 cm or something like that. Okay, maybe in China, they're more aware, they're more worried, they do their BSE, even if they have not been educated. So in Malaysia, where the average size can be like 3 centimeters, 4 centimeters, why not we teach our patients how to do breast self-examination and teach them to do it. Usually how we do it, we teach it is that they must know they do it like towards the end of their periods. Because during the ovulation time, 2 weeks before periods is the worst time to feel because it's also lumpy. By the time they finish their period, so like maybe the 5th day, 7th day of the periods, that's the best time to feel their breast. And then the texture of the lump. So this, I love this Know Your Lemons because they even teach texture of the lump. So if the lump feels hard and when you keep on pressing, it doesn't disappear, that one is okay. But if you feel a soft lump, like a non-frozen pea, you press it, it disappears. That one, don't worry. Okay. And then also teach about lymph nodes and all that. So you can actually teach your patients how to do breast self-examination. And I like to put this up because this is the bane of women in Malaysia. Okay, why not annual ultrasound? Even the women keep asking me, can I just do ultrasound? I don't want to do mammogram because mammogram is painful. I say, you know, it's your choice, okay? But I think a lot of younger women, not in the targeted screening group. These are women in their 20s, 30s. These are working women who have access to screening. They go to a screening center, wellness center, and what happens in that wellness center? Non-evidence-based screening is happening. And what did they do? They do screening ultrasound. And this screening ultrasound, number one, it causes a lot of problems with their insurance. Because a high proportion of young women will have benign changes in the breast. They will have cysts, they will have benign lumps, okay? And the pickup rate for cancer is extremely low in this age group, right? So now you've got women who have abnormal breasts, and insurance companies do not want to cover them for breast cancer. Okay, and I have to see some of my patients, even after 2 years, right, of waiting for that washout period, the insurance say, okay, you can ask again in 2 years' time, right? And that 2 years' time, they come back for examination, and then again, they have to do an ultrasound, and again, the ultrasound has something, and again, the insurance won't cover them. So I think this is the biggest disservice for people who are taking care of their health, not realizing that at the end, they can't be covered. That means they can't even, they probably can, but their premium might be sky high, but they are not covered for breast cancer treatments in the future. So, and of course, ultrasound doesn't show the micro calcification that we can detect on mammogram at the early stages, okay? And again, ultrasound is actually operator dependent. That means the operator, the mammogram is, the ultrasound transducer is so small, you're just moving it around on the breast. You can actually miss things. And you might even pick up more things than what you should, right? And then cause anxiety. And I think one last slide that I missed in this presentation is tumor markers. So tumor markers is the other one that we should stop doing because it gives a false sense of security to people. They think that, oh, my tumor marker is normal, therefore I don't have cancer. This is someone who has a biopsy already, okay, proven cancer. So we must remember that tumor markers have high false negative rates and also false positive rates. So false positive will put a woman through hell for like 2 years because they think that, oh my God, I have cancer. Then we do even up to MRI, cannot find anything, you know. So they cannot sleep for 2 years. So I think this is a big disservice to patients. So please, please, please do what our clinical practice guidelines have recommended, which is screening mammogram. And now, because of the evidence for clinical breast examination, you can do clinical breast examination, and then you can educate patients on BSE. Okay, so actually, I have a lot more slides to go through. It's already 12:30. Do you think you have a lot of questions? Maybe you can take a break for a while and answer some questions.
Yeah. Hi, Prof. Yeah, sure. So we have about 30 minutes left. There's one question so far from Dr. T. It's again from Dr. Swaran, asking, how do you diagnose carcinoma in situ for breast cancer?
Okay, all right. Wow, this one is just the same as my upcoming slides. Okay, so essentially when we diagnose anything, we need to do triple assessment. Why is it triple? Triple means we do the clinical assessment. That means we are doing risk assessment, right? Knowing whether she's high risk or she's just average risk of breast cancer. Because we need to make decisions on how accurate we need this diagnosis to be, right? Because if a high-risk individual, you have to have a high threshold to make 100% sure diagnosis, right? Okay, so risk assessment is the first part. Imaging is the second part. The third part is the biopsy. So with these three elements, we will reach a sensitivity or an accuracy of the diagnosis of about 95%. If we just look at clinical assessment, that means we ask the history, we examine the patient, our sensitivity and specificity is only 50%. Okay, mammogram and ultrasound is only up to about 80%, right? So when we do these three things, we need to figure out what is, whether or not we need to make the diagnosis more accurate. So when we talk about biopsy here, it means a needle biopsy. So maybe I can just show you what a needle biopsy is. Okay, FNAC used to be the rage in the 90s, no longer the rage because we need to do more tests on the core biopsy specimen to make sure we know what type of cancer to treat. Okay, so nowadays we do what we call core needle biopsy, right? So that triple assessment with the core biopsy gives a sensitivity of about 95%. But we have this rule about discordant lesions. So that means if the lesion looks really abnormal, BI-RADS 4C looks really suspicious, maybe even a BI-RADS 5, right? And then the biopsy comes back as benign. What do we do next? We ask Jason lah. Jason, what do we do next? Do you know? The pictures looks horrible, BIRATS 5, BIRATS 4, but then the biopsy comes back as benign. What do you think we will do next?
I think for now, if it's benign, we just need to go back for routine screening every year.
Okay, so this is where the issue lies. When we have a discordant finding, that means our sensitivity is not going to be 95% anymore. It is only if it's concordant, all the things point towards benign lesion, then okay, we don't have to do anything. We might be able to reassess the lesion. We don't go back to screening because screening means 2 years, kan? But we reassess the lesions by maybe a 6-month ultrasound. If it's concordant, okay, sometimes we don't even do 6 months, we do 1 year, repeat ultrasound just to make sure it doesn't, we didn't miss anything, okay? But if it is discordant, that means it looks horrible on the scans. Horrible means BIRATS 4, BIRATS 5, and the biopsy is benign. We need to remove that lesion totally, 100% excision of that lesion. And how we do it is through, let me see if I have, through what we call wide local excision. Or if we cannot feel the lesion, we do what we call hook wire localization. That means we can identify the lesion because we can't feel it sometimes when we do screening. The lesion is so small. The radiologist will insert a wire and then the surgeons will remove this lesion. So the answer to that question is we need to remove that lesion. So this is one of the findings we found in the delay study in 6 public hospitals in Malaysia, that one of the independent factors for delay in diagnosis is repeated biopsies. So the problem sometimes in the government sector, the breast clinic is run by the most junior surgeon. And sometimes only the MO see the patient. So when you find something, oh no, it's benign. Oh, but this one looks so horrible. Let's biopsy again. Okay, and in the past, we used to have FNAC also. So FNAC once, and after that do core biopsy. So many times. So that is an independent factor for delay. And in our study, we found that in a patient, there was a 6 times biopsy done for that lady, you know. So I think we have to know that the threshold to do the excision is going to be very low if there is discordant lesion. Right? So that means if there's abnormality in the imaging, biopsy is normal or benign, we will take out the lesion. Okay? Right. So the types of biopsy we do for DCIS is the same thing. All right. And DCIS is usually detected on a screening mammogram where you have microcalcifications. So now I want to introduce you to this vacuum assisted biopsy. What it is really a larger needle, because our usual needle that we use, this core biopsy, is about 18, wait, I think it's 18 gauge. It's quite small compared to this vacuum. Vacuum is about 11 gauge. So it's quite a large bore tumor, large bore needle where we can get more tissues out. Okay. And this vacuum assisted biopsies, this one, it can actually suck the tissues out. So the needle is a larger bore and it has a side window. And what happens is that the contraption can actually suck the tissues. So that's why it's vacuum assisted. And then it sucks and it cuts through the tissue. So you can see the picture here. We can slowly remove the lesion also, not just make a biopsy, we can also remove the lesion. So we have used this for our mammogram detected lesions because it yields more more tissues, and we can make a better diagnosis and we don't have to operate on the patients most of the time. Okay, so vacuum assisted biopsy is one of the ways of making sure we get good lesion yield. And the other thing that we do is ultrasound guided. Because sometimes I'm sure Jason, you'll be running the clinic, kan? You will find that some lumps, they feel so big. But when you do the ultrasound, it's like a third of the size, right? So that's why having an ultrasound in the clinic is very important, because then you can make a decision. Should I do freehand biopsy or should I just get the ultrasound and radiologist to do it? Okay. For the breast surgeons, most of us can do ultrasound guided biopsies, but we leave the tiny ones, like 1 centimeter ones, with our radiologists because they have the best hands to do it. Okay. All right. So that is how we make a diagnosis even for pre-cancer lesions. Right. So I hope that answers the question. So quickly, just to sort of sum up, what are the treatments? Because I think this is also important. I think GPs may, because 10 years ago, we used to operate on almost everybody upfront. So when we talk about breast cancer treatments nowadays, we need to tell the patient the treatments are multimodal. They cannot just have one type of treatment. Most likely, they may have up to 7 or even 9 types of treatment. Some people may need 3, some people may need 2. So, and the reason and the factors that affect treatment is the biology of the tumor. So that is why the biopsies that we do nowadays is a core biopsy, and we need to have the 3 information there, ER, PR, HER2, because this type of cancers here will determine the type of treatment the patient will need. Okay, and surgery may not be the first treatment. And if it is metastatic, that means when we make a diagnosis, we usually will stage the patient with a CT scan or a PET CT scan. And if the patient has disease that has spread, surgery is no longer part of the treatment, unless the surgery is to help palliate the patient. That means maybe it's an ulcerating, smelly tumor. We can remove it so that the patient has a better quality of life. But otherwise, surgery has no role in cancer that has spread. Okay, and for early breast cancer, we need to figure out what would be the first treatment. So maybe to summarize, when we look at the types of breast cancer, we have the triple negative breast cancer, HER2 overexpressed breast cancer, and the hormone sensitive breast cancer. So HER2 and triple negative, if they need chemotherapy based on the size of tumor or based on the lymph nodes involvement, they need to do the neoadjuvant chemotherapy and HER2 therapy first. That means they will have chemo or HER2 therapy first before they do surgery. Okay, and this is very important because a lot of women, they get very stressed out. And I have to say, doctors' relatives are the most stressed out patients I see, because the doctors will tell them, the relatives will tell them, hey, get your operation done first. Go and get your operation done first. And then, you know, if you're a patient, you have a doctor relative, you will listen to your doctor relative, right? And then there's a discrepancy between what the doctors, the surgeons have recommended and to the relative that have recommended surgery first. And mastectomy is not the best treatment sometimes, right? Lumpectomy may actually be better sometimes. Okay, so it's very important to know that triple negative breast cancer and HER2 therapies are important to have their systemic treatments first, because the need of further treatments is needed only with that information, where we've done the treatments, we've done the surgery, that surgery will show whether the tumor has responded to the treatments. If the treatment didn't respond, the cancer didn't respond too well with the treatments, then the patient needs more treatments after that. So for example, like HER2 therapy, if the patient is a HER2 overexpressed cancer patient, they will have what we call the dual HER2 therapy with chemo first, and then they have their surgery. Then if the cancer disappears, it can disappear in 60% of the time. Okay, that's the fantastic thing about these therapies nowadays. 60% of the time, the tumor is completely gone. And the only way to know that is through surgery lah, unfortunately. If you plan mastectomy, it will be a mastectomy, and that mastectomy can be a negative, no tumor mastectomy, okay? So if there is no residual tumor, no need to continue any more treatments, okay? Or they just continue with the Herceptin for a year. But if there is residual tumor, that means there is still disease there. That means the patient need more treatments. It's still resistant to the treatments that we've given. So they add on other drugs, not newer, but these other drugs called TDM1, okay? And then for the triple negative one, sama. If the chemo didn't make the cancer disappear, the patient need at least another 6 cycles of Xeloda or immunotherapy. So that is why I think we need to put on the brakes, especially if we have relatives. It's not about surgery first. Some types of tumor, we need to do the systemic therapy first. Then we get better outcomes, because we will know whether she needs more treatments after completing the already 6 cycles or whatever treatments, the surgery, and then whether she needs more treatments after that. Okay, so I hope that gives an overview of treatments, not too detailed, but something that you can work on with your patients. Okay. And of course, we talked about the surgical open biopsy, which is important to make a diagnosis sometimes, like what we discussed earlier. And already talked to you all about the hook wire. White local and excisional biopsy just means white local, we remove the lump with a margin, okay? Not just the lump itself, right? And then, yeah, breast conserving surgery is a good option for patients. And even in the more recent literature, breast conserving surgery patients actually do better than mastectomy, stage for stage, okay, in the more recent literature. Okay, our literature from the 90s still present showed that mastect and lumpectomy equal outcomes with radiation with the lumpectomy. But more recent evidence show that if the patient has very early cancer, if they have a mastectomy versus they have lumpectomy and radiotherapy actually do better. Okay, so that is why we can actually really tell patients to do lumpectomy nowadays, right? But given they do the radiation. But some patients still do not want to do radiation, so they can opt for the mastectomy. Okay? All right. So we do all these types of operation, and then nowadays they have this thing called the oncoplastic breast conserving surgery, where they use flaps from different parts of the breast to cover up the defect. Okay? And then, of course, we need to stage the axilla. And most of the time, we use sentinel node biopsy. We remove 2 to 6 nodes from the axilla to know whether the cancer has spread. This is important for treatment recommendation, what sort of chemo, whether they need chemo or not. This is important. And if the lymph nodes are present, we will still do axillary dissection as we used to do long time ago. But we like sentinel node biopsy because the rate of lymphedema is much less. Rate of lymphedema, which is a swelling in the arm, is about 5% in sentinel node biopsy. And axillary dissection, it can go up to 30%. And then, of course, we have mastectomy and the immediate reconstructive surgery, where implants can be used or tissue flaps can be used for the reconstruction. And this does not at any way impair their other treatments. So people always worry, oh no, if I do all these complicated things, I might not get my chemo done on time. So I might as well do my reconstruction later. And then guess what? Once a woman has gone through treatment, they never want to come back for any more treatment. So they will usually not have delayed reconstruction. Okay. All right. And just to share with you, lumpectomy patients will need radiotherapy. And in the past, radiotherapy is given what we call external beam radiotherapy, right? And nowadays, because if patients come very early, the lumps are smaller, and the type of tumor is the benign type, we can use what we call the intraoperative radiotherapy, where sometimes the patient don't even feel that she has had breast cancer treatment, because she will have a lumpectomy, she will have a sentinel node biopsy, she'll have this radiation during her surgery. Then after surgery, she comes back for her follow-up. She needs to go on tamoxifen, and that's it, you know. So treatments can be so minimal nowadays when they're detected very early. Okay, I think we have 15 minutes left. So I think one of the biggest issue, I think, for all of us when we treat our patients is the fear, right? The fear, the denial, right? That I think that's why I mentioned before, we must always give positive vibes, because it's true. I don't think we are lying if we have positive vibes, because early breast cancer can be treated so well. The outcomes are so good. Metastatic breast cancer, even though we are controlling disease, it can be controlled. In some situation, it might become a chronic disease. Okay, so I think this is something that we need to be able to communicate to our patients, being positive about and being resilient, able to tolerate and uptake the treatments and then return back to normal. A lot of our breast cancer patients are even better post-treatment, okay? They become more effective in their lives. They know what is more important in life, and they become even like healthier than doctors, okay? Right. So I'm not going to go into too much more details. I thought that maybe you want to go through some of these documents. You can actually Actually, just Google it, will be fine. You can actually find these documents quite easily. And I think we are all part of the cancer value chain. The general practitioners obviously is in the health promotion, early detection and early diagnosis value chain. So that part, I think we can work together to make sure that our patients receive their diagnosis within 60 days. Okay. And we must know what is the pathway to the diagnosis, and we have to educate our patients. And remember, refer to breast surgeon and general surgeon. Do not refer to gynae oncologist. Okay. And if you want to have more information, or if you have patients that need more information about breast cancer treatments, you can check out our YouTube Breast Cancer Resource Center UMMC channel. There is a Malay, English, and Mandarin language video on treatments for newly diagnosed breast cancer patients. And also there's a CBE video that if you want to have a look, you could have a look and see. I think I almost got my silver triangle thing, you know. But then belum lagi lah, 84,000 lah. But then already 8 years, so I don't think I'll get it lah. Okay. So the other projects that we're doing is this thing called Rebong. So Rebong actually adds value where we try to put all these different types of parts to cancer early diagnosis ecosystem. So we need to work with everybody. And I think primary care is the main feature here. And what we do is to create optimal care pathway in the Ministry of Health, even getting private mammograms in Klinik Kesihatan itself, because Klinik Kesihatan serves the B40 community. They have no idea about screening. And unfortunately, when we do all these campaigns, not all of them will be there at our health campaigns. Health campaigns are usually attended by the same people, unfortunately, you know. Okay. And then we did social media campaigns. So I just wanted to show you this. In the KK Taman Medan, where we did our first implementation research, only about 5% of those attending clinical breast examination there. And remember, they can do 43,000 CBE a year in KK, okay, in the Klinik Kesihatan. But out of that, only 5.2% actually falls in the target age group. And we take the target age group as 40 years and above. And after we redid the optimal care pathway, we co-created these pathways with them. And then we provided the campaigns and then the supports and all this. And CSM also helped us with the campaigns and outreach. We increased the numbers of people in the 40 to 70 age group by about 10%, about 11% lah increase. But I think we should be increasing this to like 80% really. Okay, but small steps is always some steps, right? Okay, the other thing is mammogram screening. So we managed to get from no mammogram screening to about 73 mammogram screening. And this is only done between June to October in 2022 in Beacon Hospital, a private hospital. And even this year, without any campaigns or anything, they still managed to do about 19 mammograms. Okay. And for the IFOBT, because Rebong also looks into 4 cancers, and this year 5, the IFOBT actually tripled. Okay, because I think there was more educational materials, more campaigns. So they managed to get even more. And I have to say the doctors there are fantastic. The family medicine specialists, their MOs, really fantastic. And we have this course that if you have missed it last year and this year, we will be having another one in February to March. This is a 6 weeks open learning course online. And we have what we call echoes. Echoes just mean that we do discussions on cases after the completion of the course. And even now with our pilot sites, Klinik Kesihatan Taman Medan, Klinik Kesihatan Kelana Jaya, we do echoes occasionally to update ourselves about the optimal care pathway, and also like how we talked about BIRATs, how to do screening and all that in clinic. Okay, and there's also another YouTube channel that you can use for your cancer education. We have now in Malay and Mandarin. We have some in English. The breast cancer ones are in English. Just type in Rebong Cancer. Because Rebong will bring you recipe masakan Rebong. Okay, so these are all the activities lah. We did a campaign with even NCSM was there with all our friends, all the cancer NGOs. So please go through all our videos and send it out to your patients. We also have other things like navigator training courses, community nursing training courses. So I think that's all from the Rebong. And don't forget, I think Jason mentioned about the City Cancer Challenge, Greater Petaling. We are going to move towards developing plans for the city. And I think primary care will be a major part of that value chain. So I think with that, just to share these are all the cities. So we are one of the cities around the world trying to improve cancer care, and UM and NCSM have been partnering with this for the last, I think now 4 years, right? And now we are at the stage where we are actually going to do something. We're doing plans to improve cancer control in our city. Okay, thank you very much, Jason. I think that's my last slide.
Right. Thanks so much, Prof. Aishah, for sharing that. I think your sharing was amazing. I definitely learned something new today. And I echo what you said, like early screening saves lives. I think if we can encourage our friends and family to do a mammogram wherever it's processed, UMMC does it quite quickly, MCSM does it as well, different places, as well as you get the diagnosis done, the treatment's way easier. So from Dr. D, there's a question for you, Prof. Aishah. I'll read it word for word verbatim. So Emeritus William Boyd, pathology for the surgeon and physician, has stated long time ago that there's a milk factor virus that is in the ductile of breast glands that when women does not give the first breast milk feeding, it can lead to early breast cancer. What is your view on the breast milk factor?
Okay, I think I did read some of this type of literature where they were thinking about a viral cause of breast cancer. So unfortunately, it's not been proven. And I think we know even from the disease itself, it's so heterogeneous that it could not be as simple as a viral infection. So what we have now, we know cancers can be caused by viruses. So I think the two types of cancers like cervical cancer and hepatomas, these are the two that can be prevented just by vaccination. So I think we should be talking to our patients, especially those with hepatitis, and they can be vaccinated even before, right? Or even having proper follow-up if they are hepatitis B and C carriers. There are treatments available, and there are ways of actually screening for liver cancer. So unfortunately, virus and breast cancer not proven. I would say not yet. I think people have done a lot of work on it.
Unfortunately, I mean, like cervical cancer is quite easy. There's HPV, and then that's the biggest one, and it's vaccine preventable. So far, also I haven't really heard about breast virus. Yeah. So that being said, you mentioned about BRCA1, BRCA2 testing. You also brought up things like the indications. Would you advocate for risk reducing mastectomy in the GP practice?
Okay, I think what happens really, we do run risk management clinics. So patients who are BRCA carriers, they are at higher risk of developing cancers. And usually what we find is when we test someone, it will be someone with the cancer first. The first person who gets tested is usually someone with cancer, so that there's not much problems in interpreting the results. So for example, when you have cancer and you have a strong family history, sometimes when you do the genetic test, it comes back as negative. But it doesn't mean that they do not have an inherited risk, because the number of genes that we look at right now, I think for cancer panels, is about 47 genes. So even that 47 genes is not enough to address all the hereditary risk issues. So if that patient has had a test, and then let's say her family member who does not have cancer now wants to do the test, then yes, you can do it above the age of, I think in Malaysia is above 21, where they can consent for the test. And then once they do that test, if they are found to be a carrier, then we start talking about risk management. So in an unaffected individual, the recommendation for BRCA1 would be risk reducing strategies that can cut down their risk by 90%. So that means if someone with BRCA1, their lifetime risk is about 65% of getting breast cancer. So you can cut down that risk by 90%. So it comes out to about 6%, right? So it's not a 100% reduction, But yes, we do offer risk-reducing mastectomies in this type of patients. And also now, because of the use of drugs in the treatment setting, we can also offer them the test at diagnosis, and therefore the contralateral breast cancer, the contralateral breast risk-reducing mastectomy can be done at the time of their primary surgery. And this is more easily done because some of them will have neoadjuvant treatments first. So after they finish completing those treatments, it will take about 6 months. So within that time, they have enough time to do the test, get their results, get counseled about the risk-reducing strategies. So yes, it is actually done. It's nothing new actually. It's a lot of people are actually doing it. And I think all women should be given the information, because some people don't know about BRCA testing, even though they've been diagnosed with such a strong family history or even at a very young age. So they don't know, so therefore they never got the opportunity of risk reduction surgeries. Because the most important risk reduction surgery is actually for ovarian cancer. Because ovarian cancer is something that you cannot detect, cannot screen to detect at an early stage. So these people might suddenly get stage 3 ovarian cancer because the symptoms are very difficult to detect. So in this situation, we would offer them risk-reducing salpingo oophorectomy. That means both the fallopian tubes and the ovaries for patients who are BRCA1 at the age of 35 years old, and for BRCA2 is about 40 years old. So when they know they are carriers, we usually counsel them about all these risk management strategies. That is risk reduction. You can also reduce risk by taking tamoxifen and the other drugs, aromatase inhibitors, if they are BRCA2 carriers. Not many people will take this up because it is, I mean, if you don't have cancer, you're taking medications that might have some side effects. Usually they don't like it, and not a lot of people will take it up. But for intensive screening, for breast cancer will always be offered if they are carriers. Like just now I mentioned to you all, MRI screening is done routinely for the BRCA carriers, but it adds cost. MRI is about 1,000 over in PPUM. I think maybe in private it probably costs about 1,500 to 2,000 ringgit just for MRI breast, and they have to do it every year. Okay, and usually we put it with the mammogram, so yearly mammograms, yearly MRI. So every 6 months they actually get a test, so they can get what we call screening fatigue. Yeah, I hope that answers the question.
That answered the question very well. So, Prof, it's 1 o'clock already, and I think it's been very good. A lot of people are saying thank you to you, and that you explained the topic very simply and clearly. So, yes, Prof, I think thank you so much for your time. Thank you for that wonderful experience bringing us through breast cancer, especially in primary care setting. I think all of us will bring this back and realize that our role in the primary care is more important than we realize. CBEs, referring for mammograms, and not delaying in getting triple assessment done by surgeons as well. With that, have a good evening, everyone. Have a good evening, Prof. Aishah. And have a good day. See you guys next month for another exciting time.
Okay, thank you, Jason. Bye-bye.